nó lạnh quá, nó hét lại, nó queo lại. Anh ngủ vậy là sao sáng anh dậy được?
For instance, general precision in orthodontics.
When you smile at me, it eases my pain. The dark days are gone, the bright days are here. My sunny one shines so sincere, sunny. Oh, I'm so true when I love you. Sunny, thank you for the sunshine. Okay, Sunny, thank you for the love you brought my way. You get to be your all day long. Now I really do feel every dawn, Sunny. One so true, and I love you. Sunny.
Quick self-ligating brackets by Forrestart. Quickly, ceramic self-ligating bracket by Forrestart.
You let me see, thank you for the back from A to Z. My life is torn like a wind-blown sail, and a mighty rock was born when you held my hand, Sunny. I love you. imagination. I'm gonna use it to lock away your love. I've got a standing obligation never to change it, 'cause then I'd lose your love. All the girls in town are trying to get on your good side. They don't know that you ain't buying. No matter,
Lingual bracket. The flattest bracket for the best patient comfort. By Frostalent.
I'm gonna use it to lock away your love.
Iniciamos.
Hello everybody, how are you? I hope you're fine. My name is Federico Rosel and my name is Terrence Murphy. So welcome everybody to this webinar, our next webinar. We have today a very pleasure to having with us Dr. Domingo Martin. Dr. Domingo Martin needs no introduction whatsoever. He's given courses throughout the whole world, all over the world. He has acquired practice in San Sebastian, Spain. He's a past president of the Anglo Society of Orthodontists and chairman of the Basic Society. So we're very happy. Today's topic is, why we change the original rough prescription and develop the new evolution plan. So we're very excited to hear all about that. And just before we start, at the bottom of your screen, you'll see questions and answers. It's like a bubble there, so would we please take questions and answers at the end of the webinar. If you're iPad users or iOS or calling from your iPhone, it's somewhere up there on the right hand side. So somewhere here or somewhere here. So please welcome Dr. Domingo Martin. Hi Domingo, how are you?
Fine, thank you. How are you?
Fine, thank you.
Thank you for the introduction.
Thank you too, and please enjoy, everybody enjoy this webinar, and see you later.
Okay, hello my friends. Hello my friends to the west, to the east, and to the center. It's so nice to be here. I wish I could be close to you. I wasn't born to give webinars, but that's what we have to do today. I first of all want to thank Forestident, number one, for the support. Number two, if it wasn't for the Forestident, we wouldn't have the Forestident evolution of plans. So if this webinar is taking place, it's thanks to Forestident. I hope all of you are doing well. I hope that none of you have been infected by the damn virus. I hope that your families and friends are doing well. And if any of them are not doing well, I pray they recover quickly. Here in Spain, as you know, we've been very hard hit. Lots of people have suffered. I've had many friends who've had difficult problems, and we are now slowly coming back to normal. We will probably start working on the 11th, which is next Monday. And to show you proof that things are almost back to normal, I'm back in the water. And you know, when I'm back in the water, it means life is back to normal. I've been swimming now for 3 days, almost 4 days, and it's like my blood is full of oxygen once again. So let's start with our topic. And what we're going to talk about is why we changed the original Roth prescription and developed the new Evolution, now Evolution 2 appliance. And I love this because, you know, if nothing ever changed, there would be no butterflies. Isn't that beautiful? Isn't that true? And you know, if nothing ever changes, you're still doing what you did 20, 30, 40 years ago. And things have changed too much to be doing the same you were doing 20, 30, 40 years ago. And this is one of the reasons why we changed the Evolution, the Roth prescription appliance, and came out with Revolution, because things change. And one cannot stand still. One has to change with the times. Now, the question is, does it make any sense to talk about brackets in the middle of this aligner tsunami? I mean, all of us are aware that the aligners have taken us like a tsunami. This is a beautiful Japanese print from the 17th century. And as you can see, it's a pretty big tsunami. But I think aligners is also a very large phenomenon. And you know, when you look at this just recent article by a fantastic group of researchers from Zurich, which is Eliades, Peltomaki, and Papa Giorgio, published in November, they come out and say the current evidence does not support the clinical use of aligners as a treatment modality that is equally effective to the gold standard of braces. Okay? I'm not saying you should not use aligners. I'm not saying aligners are bad. We use aligners. We're using aligners in many instances, and and I know the pros and the cons. But there's one thing I agree, and exactly with what they say. It's very difficult. It's very difficult to reproduce what we can reproduce with braces. So I think braces are here to stay, but aligners will be another instrument in our toolbox. So, does it make any sense? Yes, of course it does. And it does because, as Dostoevsky said in his beautiful novel, The Idiot, beauty will save the world. And this is a really important statement. And you know, you can look at it from all aspects, but I have no doubt that beauty will save the world. But I also am totally positive that excellence will save orthodontics. I'm positive that excellence in orthodontics is what's going to make orthodontics a respected profession. It will separate mediocrity from excellence, and we have to shoot for excellence. And excellence, as Peltomaki and Eliades showed us, is very difficult to achieve with aligners. So I think that if we really want to achieve excellence, we probably need to still use brackets. And of course, we need goals. And in order to do excellence, we need to achieve all of our goals. And one of the things we did when we developed and changed the Roth prescription was to take into account all of the goals. And our appliance and all the changes we made in the appliance are due to each and every one of these goals. Every one of these goals has been thought out very closely to make the appliance as good as possible to be able to achieve all these goals. However, one of our most important goals is functional occlusion, which means we want a stable condylar position, we want maximum intercuspation equal to stable condylar position, we want central occlusion to be the same as maximum intercuspation and a stable condylar position, and of course we want stable periodontal health with all the teeth placed in the bone. Now, why do I say this? Because one of the things we did was create the first prescription ever made that takes into account function. Because function for us is the key to stability, it's the key to diagnosis, it's the key to long-term success. So we can proudly say that the face evolution appliance has taken into account function. And I will get into this. Now, before we start, let's take a short and fast historical perspective of the straight wire appliance. As all of you know, everything started in Engel, then Begg, Tweed, Ricketts, Alexander, Roth, Andrews. There's been lots of different appliances. We really feel that the face evolution is the future of what we're doing in orthodontics today. Because if we want to achieve long-term stability, if we want orthodontic stability, we need to take into account function. Dr. Andrews published in 1972 the famous 6 keys to normal occlusion. He set guidelines that had never existed before as to where the teeth should be placed. Dr. Roth fully accepted the norms of the 6 keys to occlusion. However, Dr. Roth was an orthodontist of his times, because at that time he was heavily influenced by Dr. Tweed. And you know, as the Spanish philosopher says, I'm sorry, I am me and my circumstances. So Dr. Roth could not negate, could not turn its back to the circumstances at that time. And so he heavily influenced Dr. Roth. Dr. Tweed did. So Andrews introduced the values in his straight wire appliance based on the norms, and Dr. Roth changed some values to increase anchorage, influenced by Tweed, and then of course introduced overcorrection from his clinical experience. So where does face fit in? Where does face fit in? Well, number one, when we developed the appliance and the new prescription, we did not have the anchorage problems that they did in the past. So that automatically allows us to change many, many values. Today, aesthetics plays a much more important role than it did in the past. That also has to make us think as to where the teeth should be placed to be able to obtain much, much better aesthetics. Number three, technology. Technology has changed the way we look at things. We cannot close our eyes as if it did not exist. Technology has changed the way we look at tooth positions, the way we look at torque. So this is another very important aspect that we took into account when we decided to change the prescription. And then of course, new management strategies have been introduced in our practices. Time efficiency, the importance of efficiency and time. And let's face it, the self-ligating brackets make our lives such more easier. We can do much more in a much less time thanks to the self-ligating brackets. And then of course, function, or better yet, orthopedic stability. We have seen over the years that orthopedic stability is the key to longevity, stability, and anti-aging. So this is where face fits in when we have to resolve and create the new appliance. So what does all this mean? Well, first it was Andrews who introduced his straight wire appliance. Then came Roth and changed some values. But then face came along, and what we did, we returned to some of the original Andrews values, because we don't need overcorrection today with the mechanics we have, with everything that we've introduced that they didn't have in those days. We've changed many anchorage requirements because of TADs, micro screws, so many different appliances we use today to increase our anchorage. We don't need to introduce the anchorage in the appliance. And then of course, the CBCT and the new aesthetic requirements. So see, we're based on Andrews, we're based on Roth, but we've taken the revolution of the Roth prescription. We've taken it one step further. And we've done it because times have changed, because we have CBCT, because people are much more, have much more aesthetic demands, because we don't have the anchorage requirements we did. We don't have the anchorage requirements today as they did in the past. So let's see this in action. I'm going to present one patient and only one patient, and this will be used in order to explain all the different changes and why they were made in the evolution appliance. So this is our patient. She's a 19-year-old girl. Her chief complaint is dental aesthetics. She has no other problems. She doesn't have a skeletal problem. She doesn't have TMJ problems. She just is complaining about dental aesthetics. And when you look at her smile, we definitely all agree that she has an aesthetic problem. So when we look at her teeth from very, very close up, I look at this and I'm very concerned. See, we cannot only look at teeth. For example, the first thing I see are recessions. I see recessions on the canines, the first, the second bicuspids, on the right, the left, the upper, and the lower arch. We have to ask ourselves, why all these recessions? She's only 19 years old, okay? And then we have recessions in the anterior aspect, where the lower incisor is slightly coming out of the bone, and we're having a recession of the lower incisor. She's only 19 years old. And then negative torque on the back. And this negative torque, without any doubt, plays a role in these recessions. But then we cannot forget functional occlusion. When I see these recessions, I'm not thinking about a toothbrush. I'm not thinking about external factors. I'm thinking about occlusion. When I see these recessions, I'm thinking this is occlusal overload. This girl is probably is not in a stable condylar position. So this now becomes part of my equation to come to the correct conclusion. And then of course, we have crowding, tooth wear, and lack of overbite. Now, can you imagine if we do nothing, what will she look like when she's 40 years old? Well, with this lack of overbite, she probably will have more tooth wear. She already has some tooth wear. Her recessions would be worse. So there's no doubt this is not a pure aesthetic case. This is a functional and aesthetic case. We need to give this patient function. So what have we done with the prescription to improve all the problems I just described? Well, number one, we've changed the negative torque of the upper canines, which is still present in so many prescriptions. We've gone from -3 to +2. I'm sorry, I made a mistake, and I'm definitely going to change it. I cannot believe I made this mistake. +2. Okay, we change it to +2. Then we also decrease the negative torque on the lower canines to be able to have all canines more upright. Then we completely changed in face evolution 2 the buccal segments. We've taken out the negative torque and we've left it to 0 degrees. So now we're going to get a much wider smile, a much fuller smile, less black corridors. And then in order to resolve the recession in the lower arch, we've created a variable lower incisor bracket. The standard is -1, but we also have a -6, and if you turn the bracket upside down, it's +6. So we have -6, +6, and -1. So now we can compensate the class 2s, we can compensate class 3s. And this girl, because she does have a slight class 3 tendency, and we don't want to bring these lower incisors forward, we will use a -6. So with the prescription, we're going to be able to correct the negative torque of the back teeth. We're going to be able to improve the recessions. We're going to give her a much wider smile. We're going to reduce the black corridors, and we're going to reduce the possibilities of further recessions. So let's look at the upper and lower cuspids and why we changed the torque, the tip, and the overcorrection. Well, if you look at a case like this, you can see that there's some very, very thin tissue here, and you can almost feel the bone here. And even though we're not going to raise a flap, when I look at cases like this, with negative torque and with the root hanging and touching the buccal bone, I think of many instances where I've seen this. And I've done more than 450 orthodontic cases. I've been in the surgery room many, many times. And I've seen fenestrations. I've seen dehiscence on many of my patients in the past. So when I look at canines like this, there's no way we can use a negative torque bracket on this. We need to bring these teeth back into the roots and back into the bone. We need to place a positive torque. So this is one of the reasons why we changed the prescription. And this is a study by a Swiss group, And you know, if people realized that we have a thickness of 0.5 to 0.7 millimeters in the buccal bone of the maxilla, we would not do so many crazy things. I mean, can you imagine? We work in a field of 0.5 millimeters from canine to canine, and it doesn't get much thicker. So when you see the negative torque, and when you see those canines sitting on the buccal bone, the first thing we want to do is bring those in. There's no way we can use a negative torque. So this is the lateral head film. Lack of bone on the lower anteriors, and we have some crowding. And this is producing recession, but you can see that these lower incisors are also slightly pushed back. We have wear facets on the bicuspid and the canines. This automatically is telling me we have working interferences. Now, why do we have working interferences? Well, it's almost the reason why is because we don't have an MIC-SCP coincidence. We don't have a COCR, which we used to say in the past, coincidence. There's a mismatch between the joint position and the teeth position. So now we have balancing, we have working interferences that produces these wear facets. And of course, excess tip of the back teeth. Then when we look at the left side, once again, the lack of bone, the recessions, and the crowding, and once again, tooth wear on the canine and the first bicuspid. And you can say, well, that's normal. Well, I don't think it's normal, number one. Number two, it's telling you something. It's like playing detective. We have to play detective. When we do a diagnosis, we have to look at absolutely everything. So once again, this is telling me that we have working and balancing interferences. So now I know that this woman is, and we also have excess tip, she's suffering probably from an occlusal-related problem. And what did I say before? The recessions are probably due to occlusal overload. Well, it's not only occlusal overload, it's working and balancing interferences. So what have we done with the prescription to improve this? Well, negative torque of the lower incisors. We've introduced the -6, the +6, and the -1, like I said before. And then we've reduced the amount of angulation of the teeth. And this is something that Dr. Roth did because of the tweed influence. Because in the past, everything was done to prepare anchorage. More extractions were being done, and we had no other means for anchorage. So one of the things Dr. Roth did was give the teeth more tip, more rotation, distal rotation, to increase the torque. We no longer need this. So we've taken out this amount of rotation because we don't have very many cases with maximum anchorage. In fact, today maximum anchorage has almost disappeared from my vocabulary. The great majority are minimum anchorage, and the large majority are medium, low anchorage cases. So we don't need this amount of tip. And in the lower arch, we took it from 7 to 2. And then the lower incisors, we changed the prescription because of CBCT. Today, thanks to CBCT, we can make cuts, we can see the amount of bone, and in many instances, we have no bone. So if we have no bone, there's no way you can take these teeth any other place but to leave them alone. However, sometimes we will be able, thanks to the amount of bone present, to be able to give a +6, or the amount of bone present to give a -6. And this is thanks to CBCT. And CBCTs have helped us look at the upper incisor, the lower incisor, to place the teeth in the correct position and place the teeth in the bone. See, we give importance to cephalometric values, but for us, we don't care the numbers that exist in many of these patients, because what we want is the teeth to be in the bone. And sometimes the lower incisor can be at 90, it can be at 80, it can be at 110, it doesn't matter. What's important is that the lower incisor is in the bone. And what's important is that when we sit down and do our diagnostic and treatment planning, we're looking at the right prescriptions in every case. So this also changes, and it's a paradigm shift. We no longer take the bracket set and put all the same brackets on all the same patients. We're thinking, what brackets do we want to put in every patient? So in some patients, we will say, well, let's change this bracket to this bracket. Let's change this torque values, because we're thinking of every patient, of how the cases, how the occlusion looks on the mounting, the discrepancy, the interferences, the condyle positions, and the bone levels. All of this is going to tell us which brackets, which torque values we need for every tooth. So once again, we take into account the amount of alveolar bone, and this is going to help us correct and choose the correct bracket. Let's look at two examples. One is a class 2, and another is a class 3. This is a little girl who came to our office. As all of you can see, this is a severe class 2. When we look at her growth potentials, we doubt that the mandible will ever reach an ideal position. Her growth is more forward and up. And if we open the facial axis, we're going to post-rotate the mandible. So we try to maintain her anterior growth. We don't want any posterior rotation. We try to avoid the anterior rotation, and we have to compensate a class 2. So this is the case with the face evolution +6, because we're doing class 2 compensations. This is the final result. And this is, you can see, the patient pre and post. We reduced slightly the torque of the upper incisor, but we did protrude the lower incisor as much as the bone allows. However, as you can see, we have very good symphysis that allows us to do these kinds of changes. So this is our patient pre and post. We didn't expect the mandible to be any further. However, it did come slightly forward. We did not post-rotate the mandible. We did not out-rotate the mandible, and we got the amount of growth that was expected, or that the patient had. And this is her final smile. So you can see with the +6, we can compensate class 2s. And when we have class 3s, here you have a patient who has a slight class 3 tendency. You can see the upper incisors are slightly back, the lower incisors are slightly forward. But once again, we have a very nice symphysis. And so we can bring this incisor slightly back, maintain it in the bone, and protrude the upper incisor. So this is the case. We place brackets in the upper and lower arch, as you can see. We also place skeletal anchorage on the mandible between the canines and the lateral rows with class 3 elastics, a biplaning to disarticulate. We place -6. Still up and down. Sorry about that. We placed the -6 brackets. You know, this copy and paste is sometimes a traitor. So this is our class 3 compensation with the -6. And here we have our case pre and post. And you can see we brought the lower incisor slightly back, but we maintained it in the bone. And we slightly protruded the upper incisor to achieve a very nice facial result and a very nice occlusal result. And this is our patient post-treatment. And now let's talk about our functional occlusal goal. And I like to talk about the functional occlusal goal as it relates to aesthetics. And you know, this is incredible what Dr. Angle said in 1970. Everything we do, conscientiously or unintentionally, can produce harmony or imbalance, perfection or damage, beauty or ugliness of facial proportions. Therefore, facial aesthetics deserves special care if we want to provide excellent service for our patients. But you know, facial aesthetics is directly related to functional occlusion. And I want to show you this. I want to make you aware how important occlusion is for aesthetics. Here we have a case. This is the girl that I was showing you. This is her maxilla. You can see we have compressed buccal, the right and the left. You can see the gingival resections. Probably due to a combination of factors. The gingival resection is due probably to this lingualization and the torque of the bicuspid, but there's also occlusal overload. We can see the wear on the canines, we can see the wear on the bicuspids. But what's important is we can see the hanging cusps and the torque of the second molars. And this is one of the most important aspects of functional occlusion. And what have we done with the prescription to improve all of these problems? Number one, we've corrected the torque of the buccal segments. We no longer have -7, we have 0 degrees, as I said before. This will place the teeth in the correct position in the bone. It will improve the recessions, but once again, it will give us a much better arch form. We've corrected the negative torque of the molars. It's been anywhere from -17 to -14. We placed -30, and then we used the true arch form. So the fact that we have 0 torque on the bicuspids, negative torque, and the arch form has done miracles for us to obtain the aesthetics and the function. And it's so important to have a wide arch form in the front in order to be able to move the mandible to the right, move the mandible to the left without any interference in the front. Because many times when you have a tapered arch form or a Gothic arch form, when you do the mandible movements to the right or the left, you might get interferences on the laterals and the centrals. And this produces tooth wear. And tooth wear happens when you chew. And when you chew and you have interference in the front, this will produce tooth wear. So it's very important to get very nice upright canines, a broad arch form in the front to be able to avoid interferences when the patients are chewing. And then we've changed the torque of the second and first molars to -30. Dr. Roth had -17, then he went to -14. We've introduced -30. -30, to many of you, seemed like an exaggeration. To many of you, it seems like we're going to take these teeth out of the bone. But what you don't understand is that there's so much play of the arch wires inside the slot. Look at this tube. It's not a forested dent tube, but we won't say from where it comes from. But there's a 17-degree play. I mean, if you put a -17, you're getting 0. If you're putting a -14, you're getting +3. See, so we placed -30 to be able to get -14. And this is why we've introduced a -30 degree torque in our upper and second molars, because this is what's going to help us do a lot more with just arch wires and the tubes. See, almost all of the rest of the prescriptions in the market today are very far from -30. In fact, we're the only prescription with -30. We have -16, we have -14, -17. No one has -30. It's impossible to correct the torque of the second molars if you don't have at least -30. And I'm going to show you this. And this is why I said that the face prescription, the Evolution Appliances, is the first prescription that takes into account function. Because you're going to see that the second molars can make you or break you. Every time I see tooth wear, every time I see abfractions, every time I see recessions, every time I see relapse, if I take a mounting, almost in a large majority of these patients, I see orthopedic instability. And orthopedic instability due to the second molar, which will not allow the mandible to see correctly. So this is why we introduced the -30, because function is the key to stability and aesthetics. See, work hard and play hardly. And this is one of the things that I must agree, the precision of forested dent. When Dr. Ayala and Dr. Pedro Cordova did their study on the play, they came to the conclusion that the forested dent brackets had much less play than all the rest. And that's why we say German precision in orthodontics. You can see these images with a 1925 stainless steel in a 22 slot, very little play. But when you go to a 21, 25 in a 22 slot, you can see that there's almost no play. So we've come up with a very good bracket, and on top of that, with -30 degrees for the second molars. So this is the situation we see all too often. The hanging second molar cusps on the second molars. We have an increase of Wilson, which produces posterior interferences. And what do we see? We see the hanging cusp, and we've corrected it with TPAs for many years. And what did we do with the TPAs? We intruded the second molars, we corrected the curvature, and we eliminated the interferences. However, it's a lot of work. And let's face it, it's not nice to increase, to place and take out, place and take out, place and take out a TPA on every visit, which is necessary if you want to correct this torque. So you can see that we were very, very successful with TPAs. But today, with the -30, and you can see that this was done with TPAs, and we can achieve it, there's no doubt. But today, we no longer use TPAs to correct the torque. See, we do it with the -30. Sometimes we will use TADs, but we don't use TADs to correct the torque. The TADs are there to help us correct the torque, but the TADs are used for vertical control. So the TADs help us intrude the second molars, intrude the first molars. At the same time, we're correcting the torque. So here you have an example of hanging cusps and the torque of the second molars, a large increase in the curve of speed. We place in our brackets, and this is the case 6, 8, 10 months post-treatment with an extraction case. And now you can see that we've leveled the curve of Wilson. And this is before and after. No auxiliaries were used, no TPAs, no TADs, just the -30 prescription. This is another case. Once again, we change it. You can see here, there's a little filling here on this bicuspid, and there's a little filling on this bicuspid. And why do I say that? Because now you can compare. Here you see the filling, here you see the filling. It's the same patient. And look at the beautiful, beautiful position of the 6s and 7s, only with the -30 prescription. Is this important? Why is it important? What implications are involved? Well, it's important because inadequate torque of the second molars, the hanging palatal cusp, can produce muscular adaptation, change in condylar position, and orthopedic instability. And this leads to orthodontic relapse, recession, abfractions, sometimes TMD problems. It's an important issue. We cannot disregard the second molar. So now this is the hanging cusp, the increased curve of Wilson. And look, the condyles are placed out of the fossa. This is the same patient. This is a frontal view with the CBCT. This is the panorex. But when we look at the condyles, just the fact that they have palatal cusps hanging down and the 7s are out of the position, the condyles are out. You can see the patient has fixed retention. She's a post-orthodontic patient, but she came to our office for TMJ pain. See? So we have to take into account this can be the beginning of many, many problems. And here you can see the patients bite at MIC, because that's where all patients bite, but at the expense of the condylar position. And this is what happens in many instances due to the hanging palatal cusp of the second molars. And this is why we talk about orthopedic stability and orthopedic instability. When we have orthopedic stability, we have harmony between the joints and the muscles, the joints and the condyles, the teeth and the joints, the teeth and the muscles, and we have no problems. And this, as what Dr. Okas insists, doesn't produce tissue injury. So see, why do we want orthopedic instability when we can achieve orthopedic stability and give our possibilities to give the possibility of our patients to not suffer tissue injury? So, is it important? Of course it's important. It's very, very important. Let's look at some more examples. Here you see another case. No more TPAs. Look at before and after. Incredible, the amount of torque we got just from this -32s. Another example. And why am I being so repetitive? Because for me, this is a very important aspect of our prescription. Before and after. Look at the second molars. Look at the second molars. Look at the amount of torque that we achieved just by filling in the slots. And this is what I say. This is all about orthopedic stability. Orthopedic stability prevents relapse. It gives us articular stability. It prevents tooth wear. It prevents TMD. It prevents abfractions. It prevents recessions. Why would we not want orthopedic stability for all of our patients? So, as all of you know, we have a dental aesthetic goal, we have a facial aesthetic goal, we have a functional occlusion goal, a periodontal health goal, a TMJ health goal, an airway goal. We of course want long-term stability and patient satisfaction goal. But today, we've come out with a new goal, and it's anti-aging orthodontic movements. We feel that today, with the orthodontic movements we do, we can become an anti-aging factor from a very young age, because many movements go in the exact opposite direction. Let me give you an example. We showed you the negative torque. We showed you the excess gingival exposure, the tooth wear, the tongue. Look at the tongue. We see this so often. People say, oh, my patient has a tongue thrust. I can still remember Dr. Williams saying, the tongue in many instances is God's splint. When you see a tongue, think, maybe the patient is not in a stable condylar position. Maybe the patient doesn't have ability. Forget about the tongue and the what do you call it? The tongue habits. See, so when I look at the negative torque, I look at the excess gingival exposure. This is an old dentition. We need to rejuvenate this dentition. And don't forget, she's going to be 40 one day. And this is a message I would like to convey and to share with all of you. Don't look at your patients thinking, what will they look like when I finish my case? Or 1 year or 2 years. No. Think about your patients when they're young, that they're going to be 40 years old. Do we want recessions when they're 40 years old? Do we want tooth wear when they're 40 years old? Do we want this type of negative torque when they're 40 years old? No. Do we want these black corridors when they're 40 years old? Insufficient tooth exposure at rest, a poor smile line, slight lip incompetence. Do we want this? No. She's going to be 40 someday. So, what have we done for anti-aging? Well, we've given positive torque on the canines. We've removed the negative torque on the back teeth. We've given her a broader smile. Because of the upper right canines, we have a much wider intercanine width of the canines, which gives us a much fuller smile. Increased torque of the upper incisors for more anterior projection, better lip support in repose and upon smiling, and important for function and condylar position. And the use of working brackets. The use of working brackets is very important in cases where we need more torque, like in these canines. And of course, the importance of orthopedic stability to avoid tooth wear and a protruding tongue. And don't forget, tooth wear is a very important aging factor. So we've introduced the working brackets. We use the working brackets for canines that are in the place of laterals, or where we need to bring the roots back and get a lot of amount of lingual root torque to be able to hide the roots of the canines. When we have lingualized posterior teeth or exaggerated negative torque, of course, once we correct the torque, we place a normal bracket. For example, this is a perfect case where we see an exaggerated negative torque. +2 or +3 is not going to be enough. So we use a +20. We can turn this bracket upside down and get -20. So we can both wait. We bring the roots in, bring the roots out, or bring the crowns in, or bring the crown out, for example, in the lower arch. So when we have exaggerated torques, we use the working brackets. We use the working brackets not only on the canines, we put working brackets on the canines, the bicuspids, to be able to get everything out, and then we put working brackets on the lower canines and the lower bicuspids to bring everything up. It makes our job much easier, much faster, and we get incredible results in a shorter time. And you can see that the working brackets are very important in many instances. So before we continue, let me explain to you that we recently started a new face group on Facebook. It's called the Face Revolution Orthodontics. Join the revolution. It's been in use now for just a little over a month. We've got more than 3,000 people. We've got incredible cases where we take into account the the face philosophy principles. We want to show you how we do what we do, and we have doctors presenting from all over the world. So here we are on Facebook, and I ask you to join and be part of the face revolution. Join the revolution. So back to our case. This is the little girl, 19. Of course, I'm getting old, so everyone looks like little girls to me. So now we need to make a decision, because this is the discrepancy, and this is the discrepancy. So we do have a discrepancy. And if you look here, you can see where she's wearing her teeth. Here's the case where the tooth wear is happening because we have interferences on working and balancing. And you look at the condyles, we can see that there's too much space here, less space here. This condyle is down and back, and this condyle is down and back. So we have two distracted condyles with little flattening, which is usually due to overload. And you can see the left condyle has a lot of distance between the fossa and the condyle, so we have both condyles are distracted, but the left much more than the right. So, as you can imagine, we're going to start with a splint. And we use the splint because this is our formula, 1, 2, 3, and 4. It seems like a very simple case. Oh, a little bit of stripping, let's put an aligner, let's put some brackets, we can resolve this case. But you know what? Because of the thorough diagnosis, and this is what we do in the face group, is we dedicate time and energy to diagnosis. This case is not started with orthodontic treatment. It started with diagnosis, and we're gonna seat the condyle and place the condyle in the fossa. We're gonna use a splint, and then we'll talk about the true diagnosis. So this is our patient post-splint, and you can see we have a much larger class 2, a much larger overjet, and an open bite. It has nothing to do with the case that came into the door of our office. See? And now we understand why she has tooth wear, why she has recessions, and why she's got the importance of the second molars in this case. So we do our post-splint setup, and we see that it's a vertical case, so we can treat it orthodontically. And now we start by cementing the brackets. And of course, our bracket of choice is the Face Evolution 2, which is a self-ligating bracket. And I hear so often, oh, doctor, side-flating brackets are too complicated. Well, let me show you how complicated it is to open up a self-ligating bracket. I mean, anyone can do this. Look how easy it is to open up the brackets. I can change an arch wire in a matter of a minute. And then look how easy it is to close the bracket. So see, to remove and place an arch wire is this simple. And today, because of the improvement of the clips, we have very, 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 very few clip failures today. In fact, I can't remember when a nurse complained about a clip failure. And now another way to open it is by using this instrument on the clip. I prefer the other method, but this is also a valid method. Look how easy it is to open up the clip, and how easy it is to open up all the brackets and to remove an arch wire, and how easy it is to put in a new arch wire and close the brackets. So it's so easy to open and close that this is what I feel is an important aspect of management today in the office. The chair time has been reduced tremendously thanks to the self-ligating brackets. So now we've got a new mounting, a new condylar position. We have a new treatment plan. So we're going to do segmental mechanics. I don't want to protrude the lower incisors. We're going to do some intraproximal reduction. We're going to use some mini screws to intrude the back teeth out to rotate the mandible to correct our class 2, our open bite, and get an overjet and overbite correct. And we'll do this with the Evolution 2 applied. So we put in some separators prior to reduction, and then we do some intraproximal reduction. The patient continues to wear the splint throughout this entire phase. We don't want to lose the condylar position. We want the patient to bite in this exact same position. But there comes a time where we need to take off the splint and start doing orthodontics in the upper arch. So we put in some bite razors on the lower arch, constructed with a wax bite so that the patient has the same arc of closure. These bite splints maintain the condylar position, but at the same time, they're also helping us intrude the lower molars. Once again, we do not want to protrude the lower incisors. We've done our intraproximal reduction, and now we place the -6 torque brackets on the lower incisors. We've done our intraproximal reduction in the upper arch because we don't want to protrude the upper incisors as well. And then we place our brackets in the upper arch, and we place our TADs on the buccal and the lingual. And like I said before, we use the TADs to intrude. At the same time, it's helping us correct the torque of the second molars. We remove the bite razors, we remove the mini screws. The open bite has been closed. We have obtained a fantastic overjet and overbite. And now we put in some up and down elastics with a class 3 vector to make sure we bring the lower incisors back for good interdigitation. And you can see the different stages in correction of hanging cusp of the second molars. This is the way we started. She was wearing the splint. The splint also helps us control the vertical by the occlusal forces. Then we place in our brackets with rectangular arch wires. We start to fill in the slot. We place in the mini screws, and little by little you can see that we've eliminated the hanging second cusp on the second molars. And now if you compare pre and post treatment, you can see that we no longer have the second molars interfering with the arc of closure, and this will give us orthopedic stability. So this is our patient post-treatment. You can see we have a beautiful wide arch smile, upright teeth, upright canines, very, very little buccal corridors, beautiful smile, very nice profile, slightly lip incompetent, but very slightly. But like my wife says, if you look at any journal today, beauty journal, almost all models are slightly lip incompetent, so it's not something to worry about. A beautiful smile, good lip exposure, good gingival exposure, good support of the upper lip, good support of the lower lip. And this is the final result. And now when you look at this case, you can see that thanks to the positive torque on the canines, thanks to the positive torque on the bicuspids, and thanks to the less negative torque on the lower arch, we've got a very nice wide smile. The intercanine width has been increased easily between 3 to 5 millimeters. This gives us a much wider smile. We have function. Look at the 1 millimeter overjet at the canines. This is exactly what we need for the immediate side shift. We no longer have now any interference in working, no interference in balancing, and she will never wear her teeth as long as she maintains this. So this is the right side. The left side, you can see we got very nice interdigitation. This is the two arch forms. And now you can see that this is our anti-aging effect. The positive torque of the upper and lower canines, the positive torque of the buccal segments, the wider smile as the canines are more upright, less buccal corridors due to the positive torque, less gingival exposure of lateral buccal segments due to positive torque. And this is what we call our anti-aging orthodontic movements. And when we look at this, we can see that we've increased her exposure at rest. And this definitely has a rejuvenating effect. She's going to be 40. If she would stay like this, by the time she's 40, she would show only her lower incisors and no show upper incisors. Look at the beautiful exposure of teeth in repose now. This is anti-orthodontic movements. More tooth exposure at rest. So now, when we look at the entire case, we can see that we've achieved our dental aesthetics, we've achieved our facial aesthetics, we've achieved our functional occlusion, we've achieved periodontal health, we've achieved TMJ health, we've achieved airway, long-term stability, and our anti-aging movements. So this is the final Panorex. Thank God, 48 is in a terrible position. I will have no problems in convincing the mother and father to extract this third molar, and I will extract the third molars, and I almost always do it because don't forget the third molars can also have hanging cusps, can also be an interference, and can also change the arc of closure and produce orthopedic instability. So before that happens, we want the third molars out. You might say, well, you got some recession, you got some root resorption on the central and lateral incisors. Well, when you look at the lateral film from the side and you look at the frontal head film, you can see we have very nice roots, so I'm not concerned about tooth resorption. Airway is very, very nice, 254, the smallest diameter. Our condyles have seated slightly upward and forward. You can see we have much less space here, more space here, less space here than here. We've got definitely some condylar changes, but what's important now is that we have condyles at the same position as the joints. So this is our before and after case. This is before and after. You can see the amount of distance from the canines for a much wider smile. You can see the positive torque on the back teeth, the more upright segments of the lower arch, the beautiful gingiva now on the lower incisors with the teeth are now placed back into the bone. And now when we take our mounting, you can see that we have MIC is equal to CO, which means the patient bites in one position. This is orthopedic stability. Orthopedic stability is going to give us longevity, lack of tooth wear, etc., etc. So when we look at this, we can see that we've achieved all of our goals. And what's most important is patient satisfaction. And this is what FACE is all about. FACE is about goal-oriented treatment. But today, thanks to the FACE Evolution appliance that was made by Forest Dent for the FACE group, we now have the appliance to help us achieve our goals. And I want to thank Forest Dent for the effort they did for us, because this has changed the way we do orthodontics. And today, with the appliance that helps us achieve our periodontal health goal, our T&J health goal, our functional occlusal goal, we can achieve orthopedic stability. So I want to thank all of you for your attention. I want to say hello to all my friends. I miss all of you, and I cannot wait to take an airplane and visit all of you. Goodbye. I'm ready for questions.
Thank you very much, Domingo. Thank you very much. We have a lot of questions, right?
Absolutely, Freddie. The feedback has been immense. Some very interesting questions there. But first of all, from one particular participant, yeah, great going, he says, or he or she says, answers to many of my questions in practicing 40 years of orthodontics. That isn't something.
I just celebrated 40 years, so he must be a friend of mine, or she must be a friend of mine.
Yeah, I'll kick off.
Yes, sure.
Yeah, some with very, very interesting questions. What's your experience with with the minus 30 torque? With how it may flare up the anterior.
Oh, that does not happen. I mean, don't forget, we've got an arch wire that's filling in the slot. We've got so much friction in this arch wire that there's no way. I mean, the torque values are so far back, it has very, very little effect on the anterior teeth. It's not my experience. However, if it did happen, it's so easy to recover from. Because for me, we work from one. Our Bible is 1, 2, 3, and 4. The back teeth, the condyles, the back teeth, and the front teeth. So once I get the condyle seated and the back teeth correctly positioned, now I take care of the front teeth. If they're slightly protruded, I'll take care of that. But it's not my experience.
Next question. In the first case, the first class 2 case you showed, what did you use to correct the sagittal discrepancy?
Well, I think I said it. Her growth potential. She was a 12-year-old, 13-year-old girl. She had 3-4 years of growth. I could not present everything in a 40-minute, 45-minute presentation, but when you looked at her cephalometric values, she had an anterior superior growth potential. Her mandible was growing forward and up. So in cases like this, we use turbo bites. We want to hold the anterior rotation of the mandible, and we want to get the maximum expression of her anterior growth. We corrected it by growth. And you know, when you protrude the lower incisors with the +6 torque value, you're also bringing forward the lower dentition slightly, like they do with functional appliances. So it has a functional appliance effect where we're bringing forward the dental alveolar bone with the lower incisors, and you short class 2 elastics and growth.
And what about in class 3 patients giving -6 torque in the lower incisors? Will that drive the roots labially, or?
Well, you know, this is why I said it's so important to use a CBCT, and unfortunately CBCTs are being questioned in many countries. It gives us so much information. So when I have a class 3 and I see that I can compensate the class 3 with a combination of orthodontic expansion, face mask, skeletal anchorage, palatal anchorage, and I want to place the lower incisor in the correct position, and there's no doubt in a class 3 I will always place a -6. If I don't have enough bone, I will place a -1. Okay, but if I have enough bone, I'll put up -6, but I will never use a plus value in a class 3 case. But the decision to put a -6 is based on the amount of bone I have with the CBCT that I use to look at the bone.
Here's another one. What's the difference between -30 torque in the tube as opposed to -30 palatal crown torque on the wire?
Actually, we have a lot of questions regarding this 30 degrees in the buccal tube. Some questions like it's not really clear why this 30 degrees. Maybe you can tell us something.
Well, let me answer the first question. You know, if you only use an arch wire, it's so far back the torque. You know, you need lots of force to create torque. And you know, when you put in only an arch wire with -30, it's going to die out by the time it reaches a 7. It's not going to have enough force. So, I mean, the best of both worlds would be to use the torque value in the arch wire and the tube, but you don't need it. The tube will give you enough, but you need to fill the tube. You need to put in a 21, 27. See, you don't get your torque values with a 16, 22, 18, 25. And this is the problem with many orthodontists. They don't fill in the tubes. So if you fill the tube with a 21, 27, you're going to get the full torque expression. But we still have, even though it's German precision, it's not absolutely perfect because perfection doesn't exist. You always have a little bit of play. So you have to wait, you have to give it time, okay? And why did we use -30? Well, because of the values that Dr. Andrews came up with which -14 and -14, it changed from -14 to -17, and we realized that -14 wasn't enough because we had so much play that we needed to bring up the palatal cusps in order to avoid interferences in the back, and -30 was going to give us the -14, -17 that Andrews described very nicely in his work.
Freddie, you.
Yes, okay, we have another question here. So, thank you, Domingo, for the excellent lecture. Can you tell us, please, did you make the comparison evolution prescription with Damon, who always have +11 on canines and -27 on the second molars?
Yes, the problem with Damon, it's a passive appliance, and because it's a passive appliance, you don't get the torque values fully expressed. There's too much play in the arch wire. See, the difference between Damon and evolution, we have an active self-ligating. Active self-ligating pushes the arch wire to the bottom of the slot, and that's where you have to have the interplay to get the torque expression. With a passive self-ligating, you don't have this compression of the arch wire in the bottom of the slot. There's too much play. You don't get enough. That's why they had to increase the torque values, because of the passive self-ligating bracket.
Thank you, Domingo. Just one final question before you go.
I'm not in any hurry.
In the first case, how long was the stent in place? And when did you decide to stop?
Well, that's a question I get asked all over the world. There's no mathematical formula for a splint. A splint can be worn between 2 months and 18 months. It depends on the patient. It depends on the problem. It depends on the situation of the condyles, the health of the condyles. Now, in a normal patient like this, the 19-year-old girl where she has no TMJ problems, yes, she has distracted condyles, but she has no symptoms. Patients usually wear the splint between 2 and 4 months, normally. A patient who has a little bit more problems with TMJ problems, TMJ pain, maybe 4 to 6 months. Then it can be increased if we have active degenerative joint disease. It might be increased from 6 to 10 months, etc., etc. So, it depends on the severity of the problem. It depends on the age of the patient. It depends on the signs and symptoms.
Perfect. We have more questions, but I think we have every question regarding the vocal tubes and this 30 degrees. And I just want to thank you, Domingo, for your participation, for accept our invitation to be part of this initiative from Forestalen, to be part of these great webinars. Thank you very much.
I'd like to thank you on behalf of all the participants today. And of course, this is just a little taste of what Dr. Domingo has to offer. So keep in touch with us. Keep in touch with my Facebook or my Instagram or your local territory manager, and we'll be very happy to keep you informed and up to date with your up and coming webinars, and hope to see you in person very soon.
Yeah, we'll see you next Wednesday, same time, same channel, in our Forestalen webinars. Thank you again, Domingo. Have a great day. Have a good week, everybody.
Thank you very much.
Just everybody, on Wednesday
we have Giorgio Jodice. Dr. Giorgio Jodice. We will have the next Wednesday, at the same time.
Don't miss Dr. Jodice's lecture. He's fantastic.
Thank you, Domingo. Thank you, everybody.
Thank you. Bye-bye.
Bye-bye.
Thank you.